Okay, so in this lecture, we're going to cover chapter 20, the heart. So in lab, what we have covered is sections 20.1, all of the anatomical structures of the heart, section 20.2, the heart valves, and then the coronary circulation, so the coronary arteries and veins. And then section 20.3, the cardiac muscle tissue, when we looked at the histology. So here are the rest of the sections that we're going to cover in this chapter, and then some of the disorders that we're going to look at that are at the end of this chapter. So we are going to start with section 20.3, the cardiac conduction system. So the cardiac conduction system is how the heart beats intrinsically. The heart is able to beat without any direction from the central nervous system, the brain, anything like that. It has its own cells inside of it that are able to keep that beat within the heart itself. So the cardiac conduction system is made of autorhythmic fibers. These fibers are able to excite the cells in that pathway themselves, and they can generate repeated action potentials that cause our heartbeat. So we're going to look at the action potential, and we're going to look at what occurs during one heartbeat caused by this cardiac conduction system. So the purpose of this cardiac conduction system is to ensure that our cardiac muscle fibers contract in a coordinated way. So we want a good synchronous contraction from the atria and then a good synchronous contraction from the ventricles. We need our heart to be in an effective pump. It's going to pump blood out to the lungs and to the entire body. So we need that to happen in a coordinated manner so blood flows in one direction and in one kind of fluid motion, which we'll go through step by step. So what is the cardiac conduction system made up of? So on the next page, we're going to look at a picture of this, but basically it's going to be like 5 chains of events. So there are these 5 little areas of the heart that are going to signal each other one right after the other. So the SA node is going to start off the cardiac conduction system, and it's what we call the pacemaker. It is what sets the beat for the heart. The SA node has the fastest rhythm, and it's going to send its signal to the AV node. Down in the AV node, conduction is going to be slowed. We are going to slow down the rate of the signal that's traveling along this pathway to allow our atria to fully finish their cycle, so their part of the cycle, to fully empty into the ventricle. And then we're going to send that signal onwards towards the ventricles. So we're going to do this through what we call the AV bundle. The AV bundle is our atrioventricular bundle. It is going to send the signal from the atria to the ventricles. The signal is then going to go to our bundle branches, which are right in the middle of our interventricular septum. So that area that divides our right from our left ventricle. And then to further send that signal deep into that myocardial tissue, deep into the muscle layer, we are going to have what we call the subendocardial conducting network, or Purkinje fibers. This is what's going to send that signal through all of the myocardium of the ventricle, so we can have the top and the bottom portion of the ventricle contract at the exact same time. So they're going to all get signals at the same time. So here's what that looks like. So again, this is more of a pathway of neurons. This is kind of a chain of events that happens just like the electrical wires in your house. So when you flip a switch, it allows electricity to come into that room and light up that light bulb. Or you plug in a blender and then you're able to turn it on and make a smoothie. You are able to use that mechanical device because of the electrical action. And we don't often see those electrical wires in our own homes. So this is kind of exactly like that. When we look at the structure of the heart and we named all those pieces in lab, these weren't on it. And that's because these are kind of the microscopic neuron network that is inside of our heart. So we're going to look at how these cells are able to control the muscle cells while just being these tiny little fibers that are really kind of spanning all of the muscle fibers of the heart. So here you can see our SA node in the upper outer portion of our right atrium. Again, this is our pacemaker. This is what's going to set the beat of the heart. This SA node is going to send that signal through the entire atria down to our atrioventricular node, our AV node. Our AV node, again, is going to collect all that signal, slow it down, and then pass it to our atrioventricular bundle, our AV bundle. The AV bundle is going to send that signal into our right and our left bundle branches. And those right and those left bundle branches are going to continue down that interventricular septum, curve up and around and all throughout the rest of the myocardium of that ventricular wall via that subendocardial conducting network, or Purkinje fibers. So here you can see in this picture from your textbook how all of these structures are connected and how we are going to link that signal from the SA node eventually all the way through all the parts of the ventricle. Okay, so what is happening in these cells as this signal is being transferred past them? So what this electrical signal does, if you remember back when you did the skeletal muscle tissue or the neurons, when we have cells that are what we call excitable, that means that they're going to have an action potential that is being able to be fired through them, or they're going to fire this action potential that sends this signal to either usually a muscle cell or another neuron to perform an action. So in this case, this signal, this electrical signal, is going to come through all of your cardiac muscle tissue cells, through the atria, and then pass through the ventricle. And so this is what's going to happen inside of those cells and allow this action potential to occur. So again, this is the electrical signal that is going to allow for the mechanical action of muscle contraction. So this is the electrical signal of how we are passing that current through the heart to stimulate our muscle cells. So the first thing that's going to happen is we have our cardiac muscle hanging out down here at what we call resting membrane potential. So you remember resting membrane potential from the nervous system and the skeletal muscle cells. We're going to have a resting membrane potential in our cardiac muscle cells of about -90. So that's where you're going to see these cells at most of the time when they're not stimulated. As soon as we receive that electrical signal, what's going to happen is our voltage-gated sodium channels are going to open. So once we have a stimulus that makes this muscle cell membrane potential greater than resting membrane potential, we're going to have these voltage-gated sodium channels open. This causes what we call depolarization. Depolarization means we're going to have an increase in membrane potential. The membrane potential is going to get more increasingly positive. And you see that as the upward deflection on our graph here. This graph is measuring membrane potential in millivolts. So this is just like if you had a thermometer and it measures temperature. We took a volt probe and it is measuring voltage. So we took a little probe, we stuck it right into the membrane of that cell, and we are measuring what that voltage is in millivolts. As more positively charged sodium ions flow into that cell, that membrane potential is going to increase and become more positive. And this is our upward deflection right here. You see, once we hit about +20, our voltage-gated sodium channels are going to close, and our voltage-gated calcium channels are going to open. So this second part of our action potential is called the plateau phase. And this is where we maintain that depolarization. So we are maintaining that increased positive charge inside of our cell. And we are doing that by opening voltage-gated calcium channels and allowing some calcium to come into the cell. Calcium is also positively charged and is going to help maintain this increased elevated positive charge of that cell membrane during our action potential. At a certain point, these calcium channels, these voltage-gated calcium channels are going to close, and our voltage-gated potassium channels will open. As voltage-gated potassium channels open, potassium leaves the cell. So potassium is positively charged. Potassium is going to flow out of the cell, and so where the cell is now losing positive charges. And so you can see our membrane potential is going to decrease, and you can see the line on our graph is going to move down and return to that resting membrane potential state. Again, this is where we have to stay so we can receive another signal to contract again. And again, we have about 80 to 100 beats per minute of our heart. So we're going to need one of these to fire about that much to stimulate our cells as we move through that cardiac conduction pathway. So these are the 3 steps of our cardiac action potential. You want to know our depolarization is of the voltage gated sodium channels are what's responsible for our rapid depolarization. So our first step to maintain that depolarization, that is due to the calcium ion. And our repolarization is due to our potassium flowing out of the cell. So know those 3 phases and the ions that are involved with them. On this graph, you can also see something called a refractory period. So this is going to be the interval where our second contraction can't occur yet. And again, this is because the cells are already stimulated and something is happening. We have to wait for them to go back down to resting membrane potential before we can stimulate them to contract again. And you see the refractory period here, this yellow bar, is going to be almost the entire length of the action potential. While one action potential is firing, we cannot have another action potential. We need to wait until this one is done and fire that action potential again. And again, a good analogy of this is like when you flush your toilet. You can flush it once. You have to wait for it to refill and kind of reset, and then you can flush it again. You can't really just flush it twice in a row because you have to let it finish doing its cycle to restart. And that's exactly what's happening here. You have to let these ions go through their cycle, their action potential, reset at resting membrane potential, and then be stimulated to fire again. You can also see here they've highlighted in this purple bar contraction. So this is that mechanical action that is caused by the electrical signal. So this action potential again is showing you the electrical current flowing through the heart, and that it's stimulating our contraction here, this purple bar. So we're going to look at how all these pieces fit together in more detail as we keep going through our PowerPoint. So our heart is going to use a lot of energy to do this. Again, in those cardiac muscle cells that we looked at, we saw that they were going to make a lot of energy, and they're going to have a lot of mitochondria in them. So mitochondria is the organelle, if you remember back to chapter 3, that is responsible for making ATP, adenosine triphosphate, which again is just the energy currency of the body. This is just what our cells are able to make and recognize and break down when they need to do work. So how does the heart do this? Well, when your heart's at rest and just hanging out, you're sitting in class, normally, kind of just your whole day, except when you're exercising, your heart is going to work off of fatty acids and glucose that you eat. So you're going to eat a meal. Your body's going to break it down into those nutrients that we're going to look at in chapter 25. 2 of those big main nutrients are fats and sugars. And so we're going to have fatty acids and sugar, glucose, be able to be used directly by those cardiac muscle cells, and they're going to be able to make ATP via this mitochondria. We do this by a process called aerobic respiration. Aerobic cellular respiration means that we can use oxygen. We have oxygen available, so that's what the word aerobic means. There's oxygen present, and we're using it to make ATP, to make energy. And again, we're going to look at this process in much more detail in chapter 25. But this is how the heart gets most of its energy. It breaks down the nutrients that you eat using a little bit of oxygen. It's going to produce a lot of ATP using the organelle mitochondria. And again, you can see here it tells you this is going to be the highest yield of ATP for our cardiac muscle cells. But sometimes this isn't an option. Sometimes your body isn't able to do that fast enough. It doesn't have enough oxygen available. Maybe it doesn't have enough nutrients available. A lot of times this is when you're exercising. So you're exercising, you're really stressing your body hard. You've been running on the treadmill. You've been swimming laps in the swimming pool. You have really been exercising. All of your muscles are requiring oxygen. And so your body is trying to deliver that as fast as possible. But at some point, that's going to max out. And if you've ever kind of ran on a treadmill or you've ever worked out and you've gotten a side stitch, you felt this. So when you get a side stitch, your body cells are unable, wherever you're feeling that pain, your body cells are unable to use oxygen and the mitochondria to make ATP. They're just not able to do it anymore. We can't meet the oxygen demands of those cells. So those cells are going to switch over to a process called aerobic respiration. So anaerobic respiration is without oxygen. So this was our aerobic respiration. We were going to switch over to anaerobic respiration, which is making energy, making ATP without oxygen. We're going to do this using a kind of a middleman called lactic acid. And again, we'll talk about this more later. But lactic acid is what it says. It's an acid. And so that is going to decrease the pH in that area, and you're going to feel that change. You're going to feel that burning sensation of that side stitch. And usually, it's going to make you slow down a little bit, or at least stop and take a few deep breaths until it goes away. And it goes away because now you've replenished that oxygen. You've now switched back over to aerobic cellular respiration, and you're good to go. So again, in times of exercise and you're stressing your heart like that, it can switch over to this process too. It can switch over to the lactic acid pathway and use anaerobic cellular respiration. This is extremely inefficient, and we can really only use this short term. Again, another short-term method of making energy quickly, we can use what we call creatine phosphate. So you guys looked at this in your skeletal muscle chapter, but creatine phosphate is just a protein that's hanging out in the muscles. Again, we have a special enzyme that's able to utilize some energy from this creatine phosphate and make us some ATP. Again, this is very short term and only really helpful in like immediate burst situations. But this is how your heart makes all of the energy to be able to keep beating every, 80 to 100 times per minute per day. So these are how we make our energy. So now that our cell has the energy, we've talked about how that electrical conduction system works. Now we're going to talk about how we measure and interpret the functioning of it. So again, I said this is not like an anatomical structure. I can't just hand you a model or show you a video or a picture and say, this is the, well, I guess I kind of did. But you can't touch this structure. Like, it's not a big 3D thing. This is, again, a network of neurons, a network of fibers that are microscopic. They're going to span through the heart muscle tissue. We can't really isolate this as well as, we can with a ventricle or a blood vessel. It's just a different type of a tissue. So we're going to measure its functioning by measuring the electricity that it puts off. Just like we measured things with that voltmeter, the cell membrane potential, we are going to measure the action potentials of the heart using what we call an electrocardiogram. So you will see this listed as an ECG or an EKG. And so again, this is going to record electrical signals of our heart. This is going to help show us how that conduction pathway is doing. Again, without us physically being able to see this with our human eye, we can interpret its functioning via the electrical charges that it's putting out. We can determine the size of the heart, right? We could also do that with imaging, but sometimes it's really helpful to see how thick a ventricle wall is and how hard the cardiac conduction system is working to get that signal there. We can also see some locations of heart damage and some causes of chest pain. Again, really helpful in kind of emergency situations. This is a non-invasive kind of study. We're going to stick little stickers where all of these dots are, and we are going to plug the little ECGs right on top of them. They are going to be able to detect that electrical current that is coming out of the heart. We then know, based on where these stickers are, what area of the heart that they are representing. So we can do what we call a 3-lead ECG, which would just have like 3 of these little stickers, and that gives us kind of a quick and dirty view of the heart. Is there anything urgently wrong? Do we need to correct something immediately? If you've ever taken a life support, what is that called? Life support training. So you've taken like a class to learn how to use an AED. They usually have a 3-lead ECG or something in them to help you see the view of the heart. We also have what we call a 12-lead ECG. So this is going to give us a more in-depth view of the heart, and we're going to evaluate a lot of different changes. Ischemic changes are changes of the heart that are happening because of a decreased amount of blood flow in those coronary arteries that we looked at in lab. And a blockage of one of those coronary arteries is what we call a heart attack or a myocardial infarction. So we'll look at why these are so important and being able to detect them quickly so we can fix the problem before it becomes more serious. So how do we read this ECG? So here is one perfect peak of one ECG kind of beat, I guess, if you want to think about it like that. This is a representation of one heartbeat in the form of an ECG. So there are several large things that we look at on here, and then there are a lot of tiny little factors. Cardiologists can analyze almost every little segment and interval and inch of this thing, and there's a lot of different techniques that they'll use. So you'll learn a lot of different ones and see a lot of different ones in practice, just depending on what that doctor likes and what condition the patient has. Some intervals and segments are going to be more helpful for certain conditions. So the three main things that you need to know about every ECG are these 3 points right here: the P wave, the QRS complex, and the T wave. So the P wave is this first little green bump. This P wave represents our atrial depolarization. So our atrial depolarization is going to be, again, our signal for contraction. Once we start that action potential, that is our electrical signal for our mechanical action. So we are going to have those atria depolarize, and then they're going to contract. So just like you plugged your blender on, or you plugged your blender in, and then you turned it on, it was a two-step process. Same here. Atria has to depolarize to get the electrical signal, and then it can go ahead and contract. And that's the current that we're seeing with the P wave. We are measuring how well is that atria preparing for contraction. After our atria contracts, our ventricles have to contract, right? That's step 2. So our ventricles are going to contract, so that is going to be stimulated by ventricular depolarization. So this peak right here, our QRS complex, is going to be our signal for ventricular depolarization. And then our blue wave is going to be ventricular repolarization. Repolarization is the signal for relaxation. So after things contract, then they have to relax to reset and refill up with blood so we can do this for the next heartbeat. So our P wave, again, atria are going to depolarize and then contract. Our QRS complex is going to be where our ventricles depolarize so they can contract. And then our T wave is going to be ventricular repolarization, the signal for our ventricles to relax. So, do the atria repolarize? Yes. We just can't see it on an ECG. The atria are going to repolarize and relax at the exact same time that the ventricles are depolarizing to contract. Those things happen simultaneously so the heartbeats can be smooth. So, while that was happening, we were having this big peak of the QRS complex of ventricular depolarization. Ventricular depolarization, the QRS complex, is going to mask the P wave that is atrial repolarization. So QRS is going to mask atrial repolarization. We can't see it on our ECG. So those are the 3 main things that you will learn how to evaluate on an ECG. Those are the 3 main basic peaks that you need to know. And then there's some specific intervals and segments. So again, there are a lot more intervals and segments than just these 3, but these are 3 very common ones that you will definitely learn more about when you get to your upper level courses. So our PQ interval, again, P to Q. So this is going to be the start of the P wave to the start of the QRS complex, P to Q. So this is going to be where the atria get excited through where the ventricles get excited. So we want to make sure that signal, what we are passing on through the heart from the atria to the ventricles at that AV node and then the AV bundle, is going smoothly. So we can evaluate that with our PQ interval. And again, we will just measure this. And if it is longer than it should be, we have a standard that that an ECG should be. And if it's longer, maybe it's scar tissue. Maybe it's taking a longer amount of time for that signal to travel from the atria to the ventricles, because at one point there was damage and now there's scar tissue. Just like when you cut yourself, sometimes you end up with a scar where you cut yourself. Where your heart's damaged, sometimes you end up with a scar where that damage was. This can be due to coronary artery disease, which we will look at in a few slides at the end of this presentation, or rheumatic fever. So rheumatic fever is kind of a common cause of this increased PQ interval as well. So again, we will put all of these pieces together and build our whole patient puzzle here to try to figure out what's going on. If we can also look at our ST segment. So the ST segment is going to be from the start of the S wave to the end of the T wave. So this is S through T. So this is going to be when the ventricles are depolarized, and this is that plateau phase of the action potential. If we see this elevated, a lot of times it's going to be a good indication of a heart attack, an MI, or a myocardial infarction. If this line right here is depressed or down here, we can say that this is ischemia. Maybe the heart hasn't been damaged yet, but it might be soon, and we know we need to do something about that. So ST segment, very commonly seen, commonly tested, really helpful when you're looking at ECGs in the hospital. And our last interval we're going to look at is that QT interval. Again, start of QRS till the end of T. It is going to be the start of that ventricular depolarization through the end of ventricular repolarization. So this QT interval is going to tell us how well our ventricle is getting that signal and passing it along. Again, if this is increased in length, we can have some tissue damage. It's taking longer for that signal to travel through that damaged tissue. So again, kind of helpful to help our cardiologists see where the damage could be and what they can do to help the heart in that area. So we are going to look at this now in kind of a broader or a more detailed sense. That was kind of a broad overview of exactly what happens during one beat or one ECG blip. So now we are going to look at exactly what happens on the ECG paper corresponding with what's happening in the heart chambers at the same time. Okay, so we see in step 1, we have depolarization of the atria. Again, so that SA node is going to fire. It is going to send that depolarization wave through the atria, and you are going to see that start of our P wave. Again, depolarization is the signal for contraction. That is our electrical signal for our mechanical action. So once we have those fibers depolarized, those muscle cells can now go ahead and contract. And so we are going to see what we call atrial systole or atrial contraction. So the atria are going to contract and finish pumping whatever blood they had inside of that chamber into the ventricles. So the right and left atria are going to contract at the same time here in step 2 and send the rest of the blood that they were holding inside of them to the right and left ventricle. Step 3, we see that signal coming down our conduction pathway, again to that AV node, AV bundle. Bundle branches out to that subendocardial conducting network and depolarizing our ventricles. We are measuring this with our QRS complex. So we can see that ventricle depolarization on that QRS complex. And then we see immediately afterwards, we see our ventricular systole or our ventricular contraction. So we can see that that QRS complex is that depolarization of the ventricular tissue, the electrical signal for our mechanical action. So now we have that ventricular systole, ventricular contraction, and we are pumping all that blood in the ventricles out into the pulmonary trunk and the aorta. You see in step 5, now that those ventricles were contracted, they now need to relax. So we are going to signal relaxation with repolarization. Again, remember those repolarization where those potassium ions were flowing back in or flowing back out of the cell. We were losing positive charges. So potassium ions are exiting the cell. We are losing positive charges, and we are returning that electrical conduction network back to its resting membrane potential or back to its unstimulated state. So that's exactly what is going to happen to these muscle fibers. They are now not stimulated. They're going to relax back to their normal position so these ventricles can fill back up with blood, kind of like an empty balloon. In step 6, we see ventricular diastole. Again, ventricular repolarization is our electrical signal for our mechanical action of ventricular diastole or relaxation. The entire heart is going to be relaxed right now. We see our atria and our ventricles are both relaxed, reset, and ready to go. They are ready to refill with blood and be re-stimulated by that cardiac conduction network. So again, really kind of helpful figure to go through in detail what is happening in each step of that ECG. So we can put that ECG into a little bit more detail. So we can look into a little bit more detail about what is happening in the heart. There we go. We can look at what's happening in the heart. I was trying to fit it all in one picture. At the same time as that ECG is occurring. So we can evaluate everything in the cardiac cycle, all of the factors that are occurring in one heartbeat. So the electrical signal, that is our electrocardiogram, the pressure changes. If we can measure pressure changes, we can measure volume changes. So we're going to measure how the blood is moving and changing volumes inside our heart. And then we can look at the heart sounds. So we hear heart sounds when our heart valves close. And our heart valves are going to close like a slamming door. They are going to prevent the blood from moving from one room to the other in the heart until the heart says, okay, open the door and let's go. And so we'll look at those as well. So a normal heart rate of 75 beats per minute, which again is about average. Our cardiac cycle, all of these things are going to happen in about 0.8 seconds. So less than 1 second, all of these things are occurring all of the time. So pretty crazy to think about the speed of the body. So what is happening in this cardiac cycle? So again, here is the picture of all of these things happening. And then here is step by step how this is happening. So we are going to see atrial systole. So if we look at when the atria contract, so we will go back up here and we will start with our atrial contraction. Our atria are going to contract. They're going to get that signal from the P wave. So the SA node is going to fire. We are going to be able to measure that electrical current as our P wave. We see that nothing is happening with pressure and volume because nothing is happening with the muscle yet. The P wave is just the electrical signal. Once the P wave signals for depolarization of the atria are going to go ahead and contract. Remember that atrial depolarization was the signal for our atrial contraction. As those atria contract, we are going to be able to see that the pressure in our atria is going to increase and it's going to send blood into the ventricle. So here we can see our volume in our ventricle increase, and we can see our pressure in our atria increase as well as the pressure in that ventricle. So the pressure in the atria is increasing because the muscle is squeezing, and the pressure in the ventricle is increasing because the volume is increasing. Remember, volume and pressure have a direct relationship. If volume increases, pressure is going to increase. So we are increasing volume in the ventricle, which is going to increase the pressure in the ventricle as well. So the next electrical signal that's going to occur is our QRS complex. Again, this was our signal for ventricular depolarization, and then that is going to trigger ventricular contraction. So here we see our ventricular depolarization going to trigger our ventricular systole, which is this purple phase. So we see that as the ventricle is going to start to contract, the pressure is going to build inside that ventricle. The pressure is going to build inside of that ventricle, and it's going to build until it reaches a certain point, and we are going to be able to eject that blood into the aorta. So you see we are going to eject that blood into the aorta, and you see you see our volume in that ventricle decrease. So here's our volume in our ventricle decreasing as our pressure's building because we're contracting, and then it's going to start to decrease because now it's passing that blood to the aorta. So again, we said the next thing that was going to occur on our electrical signal was going to be our T wave. Our T wave was our signal for ventricular relaxation. So our T wave is going to be that electrical signal for ventricular repolarization. Ventricular repolarization is going to stimulate ventricular relaxation. And that's what you'll see. The pressure in the ventricle is now decreasing. It's relaxing. And the volume is going to start to increase because it's going to start to fill with blood. The ventricle is going to passively fill up with blood, right, until the atria contract, forcefully send all that blood that's left over in them into the ventricles so they can be fully filled, and then they can propel their blood forward. So the ventricular pressure is going to slowly decrease, and then it will increase a little bit and kind of stabilize as the the volume slowly increases. Now, where do these heart sounds fit into this puzzle? Again, I said we were going to hear heart sounds when our valves closed. So you only hear heart sounds when valves close. Valves should open silently and then they slam shut. We can hear them by a technique called auscultation. Auscultation is listening with a stethoscope. So we listen for the valve sounds slightly above or below where the valve is because their sound is going to get carried with the blood. So sound kind of gets carried away on big open areas. And that's kind of what these blood vessels are in the heart. They're kind of open tubes for the blood to flow through, and the sound is going to get carried down with them. So you will learn these diagnostic skills, these physical exam skills when you get into your upper level courses, but they will teach you where to put your stethoscope and what you're hearing at each point on your chest. So that's why the doctor moves the stethoscope or the nurse moves the stethoscope on your chest. When they are listening to your heart and your lungs, we can hear different pieces of those organs at different areas on your chest. So we were going to evaluate those valve sounds. So what are we going to hear when we listen to a heartbeat? Normally we hear two sounds. They're lub, dub. So if you ever, hear someone's heartbeat, it's going to sound like lub, dub. Using a stethoscope listening via auscultation, we're going to hear lub, dub normally on everyone's heart. S1 is going to be that lub sound, and S1 is going to be when our AV valves close. So that bicuspid and that tricuspid valve, those atrioventricular valves. So our bicuspid and our tricuspid valve are going to close when the pressure in the ventricles gets so great, the ventricles are going to say, hey, I'm ready to contract. Ventricles are getting pretty full. The atria have fully contracted. They've ejected all of their blood into the ventricle. Ventricle's full, ready to go. We are going to slam that door shut behind us to the atria. When the ventricle contracts, we don't want to send that blood backwards to the atria. That's not doing us any good. We need it to go forward. So we have to close the door to the room behind us so we can propel blood forward in one direction. So that's what you'll hear with the S1 sound. You will hear those bicuspid and tricuspid, or the right and left atrioventricular valves, close. The next sound you hear is our S2 heart sound. So again, our S2 heart sound is going to be when our semilunar valves close. So that is the aortic and pulmonic valves. The aortic and pulmonic valves are going to close when the pressure inside of them gets lower. So when the pressure in the ventricle is great, it's going to force those valves open. We are going to force blood out of them. Now, when the pressure decreases and there's no blood to be pumped through those valves are just going to shut. And you notice that they were different. They were formed differently when we looked at them in lab. We had those semilunar cusps on the aortic and pulmonic valves, and we had those chordae tendineae and papillary muscles on the tricuspid and bicuspid valves. And again, that is because they're going to kind of function a little bit differently how they close. And again, the aortic and pulmonic valves are going to close once that ventricle has ejected all that blood out and the pressure now decreases. They're going to slam shut and let that ventricle fill up with blood and let the atria eject their blood into the ventricles, all while staying closed so we can propel that blood forward in one big burst. We'll look at why that's important here in a few slides. So our S3 heart sound is going to sometimes be normal, sometimes be abnormal. So with everyone, you'll hear S1 and S2. S3 you may hear, you may not hear. You might hear normally in kids, young adults, and pregnant women because of the increased blood volume. These kind of groups of people can have increased blood volume, and that can increase the turbulence or the sound, kind of the sound that we hear while the ventricles are filling. We've increased pressure in that ventricle, and we're gonna be able to hear that with our stethoscope. This can be abnormal a lot of times in heart failure, or if we have the valves not closing properly. So if the mitral valve is not closing properly and blood is going the wrong way through it, you can hear that. You can hear abnormal blood flow. So that would be the S3 heart sound. Our S4 heart sound is always abnormal. You should not ever hear an S4 heart sound, but sometimes you can. And a lot of times we see this with our left ventricular hypertrophy. So what does that mean? That means our left ventricle is big, and it has grown big due to some issue. There's lots of them, but it's gotten bigger because it's had to adapt to some disease condition in the body. This increased size of the left ventricle is going to make it less compliant. So we call this ventricular non-compliance. The ventricle is not going to be able to be as kind of bouncy like a balloon as it should be because it's going to be too thick. And so when blood hits that, you're going to be able to hear this, and that would be our S4 heart sound. So again, I just want you to be aware of them, which ones are normal, which ones are abnormal, and what is valves closing are causing the S1 and the S2. You will learn lots more about this in your upper level courses. Okay, so let's get into the cardiac physiology of this chapter. So these are some of the principles of how the heart works and kind of why it works and the factors that affect the heart's function. So this is what's going to be important when you work with your patients and they have different disease conditions or they're on different medications that affect their heart in different ways. You're going to want to know what factors are affecting the heart and what we're doing to kind of manipulate those. So what either the disease is doing to manipulate that condition and affect it, and how we are going to treat it and how we can kind of counteract that. So our cardiac output is the first variable that we're going to look at. Cardiac output is the amount of blood that the ventricle ejects each minute. So how much blood can we pump out of the heart in 1 minute? So we're going to take your heart rate, which is the beats that your heart beats per minute, and we're going to multiply it by something called stroke volume. Stroke volume is the amount of volume that your heart ejects per beat. That's going to be the amount we can measure this by taking that end diastolic volume, so the volume at the end of filling, minus that end systolic volume, the volume at the end of contraction. And that whatever we get as this value is the amount that we have ejected per beat. So we multiply the amount that we eject per beat by the amount of beats that we have per minute. And that's going to tell us the amount of blood that the ventricle is able to eject per minute. This value should be normal left ventricular, that's what LV stands for, not Louis Vuitton. Normal left ventricular cardiac output is about 5 liters. So this is almost your whole blood volume per minute. Your body is able to get oxygenated and eject. So really awesome. Like this is such a crazy thing that happens, but this needs to happen because we have to get all the tissues of your body oxygen all the time. So really important that this value is normal. If this isn't normal, we're gonna have issues with oxygenating our tissues a lot of the times. So factors that are gonna affect this are things that are gonna increase or decrease heart rate or stroke volume, right? So anything that affects heart rate or stroke volume is then in turn gonna affect cardiac output. So we are gonna look at those factors next. There's a term called cardiac reserve, which is the difference between your cardiac output at rest and your maximal cardiac output. So how much that you can put out while you're exercising as hard as possible, as maximally as possible. So they use this cardiac reserve a lot in sports medicine, and your book has mentioned the term a few times. So that's what they mean. So what factors affect our stroke volume? Again, we said stroke volume was the amount of blood in milliliters, so measured like a volume of liquid. How much volume can your heart pump out in one beat? So there are three kind of main factors that affect that. One of them being preload. So the preload is the stretch on the heart before it contracts. So this is like shooting a rubber band across the room. If you don't pull the rubber band back very hard, it's going to shoot and it's going to go only a short distance from you. If you stretch the rubber band, those elastics in the rubber band, as far as you can and let go, it's going to shoot almost the whole way across the room. It's going to go further distance. So the further you stretch an elastic fiber, the better recoil it has, the stronger it's going to be able to contract. And that's exactly what's happening with your cardiac muscle fibers. The stronger that we are able to stretch them, the harder it's going to be able to contract. And again, they call this the Frank-Starling law of the heart, just in case you see that on anything. All they're talking about is the more you stretch the heart, the harder it is going to contract. So again, this is going to be proportional to the end diastolic volume. So the greater the volume in the ventricle, the more forceful the ventricle is going to be able to contract to push that volume out. End diastolic volume is going to depend on how long were you in relaxation? How long were you in diastole? If you have a longer time in relaxation, the blood's going to be able to fill that ventricle more completely. If your heart is pumping very quickly and your diastolic phase is very quick, you're not going to refill your heart ventricle as much. And it's also going to depend on venous return. Is the blood getting back to the heart? Is there a problem somewhere else? So a lot of these factors can be affected by downstream organs, downstream problems. So do we have an issue with our venous system? Is there something blocking the return of blood to the heart? The second factor that affects stroke volume is contractility. So we can have things that increase contractility, that what we call these positive inotropic agents. We also have things that decrease contractility. These are negative inotropic agents. So things that increase contractility in the heart, getting calcium to the heart. We said calcium was responsible for the plateau phase of our action potential. So the more calcium that we have available, the longer we're going to be able to have that phase, the stronger we're going to be able to stimulate that muscle cell to contract. Stimulation of our sympathetic nervous system. So if you remember from the nervous system chapter, the sympathetic nervous system is your fight or flight response. This is your emergency alert system. This gets you up and ready to run away or fight for your life. So your sympathetic nervous system is going to be able to increase the strength of contractility of your heart by direct stimulation through the nervous system. Because in an emergency situation, we need your heart to beat quickly because we need your body to get oxygen and blood to it to run away. The sympathetic nervous system response is also going to stimulate two hormones, epinephrine and norepinephrine. Epinephrine and norepinephrine are going to be able to stimulate the heart's contractility as well. These are, again, your emergency hormones. They are released from the adrenal gland, and we will look at these more in chapter 18. Yeah, your endocrine system chapter. We also give epinephrine in the hospital to increase strength of contraction of the heart in emergency situations. So you will see this given as a medication. Digitalis is also a medication. This is a medication for long-term condition. So this is going to increase contractility on the long-term setting. It's the medication that your patient will probably take every day. So things that decrease contractility, things that are called negative ionotropic agents, inhibiting that central nervous or sympathetic nervous system, right? If we inhibit this sympathetic nervous system, we're going to inhibit that stress response, that emergency alert system, and the heart does not need to beat as strongly. Anoxia. So just lack of oxygen. If there's not oxygen available, we're not going to be able to pump the heart. The heart's not going to be able to pump as well. Acidosis. So altering pH is going to be really critical. We're going to look at this a little bit more in our urinary system chapter. But acidosis is going to have negative effects on the heart. It's going to decrease the ability for the heart to beat. Some anesthetics, again, another principle that we can manipulate for kind of our benefit, right? Anesthetics are really a great thing. We couldn't do a lot of surgeries without them. So some of them are going to be able to slow that heart rate, contractility down, and help kind of slow the patient's heart rate and kind of blood loss during surgery. We can also give long-term medications, again, calcium channel blockers, blocking that calcium coming into the heart, increasing potassium. We said potassium was responsible for repolarization, which was our relaxation. So if we increase potassium, we're going to increase repolarization, and we're going to prolong that relaxation phase. We're going to prolong that diastole. So again, we can manipulate multiple of these factors at one time, different things, different medications. There's just understanding the principles of these right now is what is important. And our last factor that affects stroke volume is going to be afterload. Afterload is the pressure that the ventricles have to overcome to pump blood out to the body. So what force is it going to take to open that semilunar valve up? As afterload increases, stroke volume is going to decrease. So the harder it is for your heart to pump against that resistance, it's not going to be able to get as much blood out, right? And so that kind of makes sense if you've ever crimped a hose, right? You've ever crimped a garden hose. If you turn it in half, no water's going to come out at all. But if you you can manipulate it a little bit, you can control how much water comes out. That's what's happening here. There can be a lot of force behind it, but if there's a lot of pressure at the end, it's not as easy for that water to come out. It's not as easy for that blood to come out. So we're going to see this with things that narrow the tube, that make that tube, the aorta, a little bit smaller. So, or any of the blood vessels downstream. Atherosclerosis. We see this with cholesterol building up and making those blood vessels smaller. Hypertension. So hypertension is high blood pressure. We see high blood pressure a lot due to constriction of blood vessels. We're narrowing a tube and now it's harder to force water or blood through that tube. That is increasing our afterload and is increasing how hard the heart has to work to pump the same amount of volume out. So afterload, preload, and contractility are our three factors that affect our stroke volume. So again, if you want to understand the big points of this, and again, you will learn more about this as you go along. So heart rate, what affects heart rate? Well, we know our heart rate normally is about 60 to 100 beats per minute. And I'm sure you can think of some things right off the top of your head that you know increase heart rate. One of them being the sympathetic nervous system, right? Fight or flight response, the emergency alert system. When we are in an emergency situation, this nervous system, again, like I said, is going to be able to stimulate the heart directly. And it's going to be via these cardiac accelerator nerves. And again, they're going to accelerate the heart. They're stimulating the SA node, AV node, and the myocardium directly. So kind of like a triple action here. We are going to stimulate everything we need that heart to beat quickly. Again, they're going to release that norepinephrine. Norepinephrine is going to increase the depolarization at the SA node and AV node, and again, increase that calcium. So we're going to increase heart rate and contractility. We just looked at in our last slide. So again, really important that sympathetic nervous system response to increase heart rate, to increase blood flow to the body. So the part of the brain that does this is our cardiovascular center and our medulla oblongata. And again, this is going to just be the kind of main area of the brain that oversees the actions of the sympathetic and parasympathetic nervous system in regards to heart and like the effects on the heart. The parasympathetic nervous system does not have a lot of effect on contractility, but cranial nerve number 10, the vagus nerve, like we've said, has pretty much innervates everything. Innervates the heart, again, the SA node, AV node, and myocardium directly. So again, triple hit here. And it's going to release acetylcholine. Acetylcholine is kind of going to be like a brake. It is going to kind of slow down how much the SA node and AV node are firing and decrease heart rate. So you can see this a lot with different yoga breathing techniques and things like that. The parasympathetic nervous system, again, not going to have too much of an effect on contractility, but can definitely slow down heart rate. So what else will affect our heart rate? Well, some hormones, epinephrine and norepinephrine, just like we said, increase heart rate and contractility in emergency situations. The thyroid hormone can also increase heart rate and contractility. And again, we'll look at this in the endocrine chapter, but this is a big symptom of hyperthyroidism, tachycardia. Tachy means fast, cardia means heart. So fast heart rate is a big symptom of hyperthyroidism. People will tell you, I feel like my heart's beating out of my chest. I feel like I can't sit down. They feel like they're running around all the time. Their heart is just beating so fast. It's like they say they're laying down and they just can't even sleep because their heart's beating so quickly. So a lot of times that'll be one of the symptoms that they come to the doctor with and say, hey, this is what I'm feeling. And we have to work backwards and figure out, oh, hey, that might be due to a thyroid hormone problem. And again, we will look at this a little bit more in the endocrine system chapter. We already talked a lot about the ions and what they do. But again, different ions are going to either decrease heart rate or contractility or both, depending on where they affect. So again, increasing sodium levels or potassium levels is going to decrease your heart rate and contractility because if you have a lot of sodium, it is going to block the calcium. So the potassium, increased levels of potassium are going to directly do this. And increased levels of sodium are going to indirectly do this via that calcium blockade. Increased potassium is going to block that whole action potential kind of generation, right? We said it's going to put that cell in that more of a negative resting membrane potential and make it harder to reach that point where those voltage gated sodium channels would open for that action potential to fire. We can also increase calcium levels. And again, that's going to increase heart rate and contractility. Like we said, that's going to extend our plateau phase of our action potential. Lots of other factors are going to affect heart rate. Just like I said, there's always a lot of other variables involved in all of these. Age, gender, physical fitness level, body temperature. We could go on and on. So there's going to be a lot of other factors that you need to take into account when you're measuring someone's vital signs. Are any of these things an issue? Or any of these other factors an issue? Are they just terrified of coming to the doctor? There's a lot of things that are going to affect the heart rate. So again, one piece of our puzzle to see what's actually going on. So what does exercise do for the heart? You're going to counsel a lot of patients on how they should be exercising and how it's going to be really beneficial for their heart. We have, they've seen, I guess, in scientific studies that aerobic activity, 20 minutes, 3 to 5 times a week, is going to really increase how well the heart functions because it decreases how much oxygen your muscles need. So to get more oxygen to those muscles, the heart's got to work a little bit harder. So we're going to increase that cardiac output. To do that, our heart muscle is going to get bigger. This is called physiologic cardiomeglia. So cardio, again, is heart. Meglia is large, like megalodon, the big shark. So physiologic cardiomeglia means a natural physiological process that enlarges the size of the heart. And so we call this hypertrophy. The muscle cells of the heart themselves are literally going to get bigger. Just like if you lift weights with your arms and you can see your biceps get bigger, this is what happens with your heart when you do aerobic activity. So when you do cardio, right? When you go run on the treadmill or walk around the track or go for a swim. Those are all kind of cardio and endurance activities. And they are going to help your heart get to a size that is really good for it and help it work at its kind of like peak functioning. Pathological cardiomegalia is increased heart size due to disease. So the heart can get bigger in a bad way. So not all cardiomegalia is good. And again, you guys will learn lots of pathological conditions that lead to cardiomegalia. Other benefits of aerobic activity that help the cardiovascular system: decreases blood pressure, improves mental health, which, believe it or not, can have a lot of negative effects on the heart. It can help control weight. So the less, weight that your patient has, less excess weight, the easier their heart's going to have pumping blood. And we're going to look at that when we look at the blood vessels in chapter 21. You're also going to have an increased ability to break down any blood clots. Again, you're just kind of be overall healthier. And this is all going to have a really positive effect on the heart and the cardiovascular system as a whole. So what can we do other than an ECG to evaluate the heart? So we can do some cardiac imaging. So here are some images of the heart. This one down here is an echocardiogram. This is an ultrasound of the heart. We have a big program for this here at HAC, and it's a really cool major. I just really think the images that come from this are super awesome. You can specialize and just do pediatric echoes. There's a lot of different kind of routes that you can take with this job. This picture over here is a cardiac MRI. Again, this is going to give us a nice kind of high resolution image based on magnets to show us the different densities of tissue. And so here you can really appreciate how thick this left ventricular wall is compared to the right ventricular wall. And you can see them next to each other right here. And again, so we can evaluate a lot of different factors. You can see the anatomy of the right and the left ventricle and the different structures of the heart really well. With the echo, we're going to be able to see the blood flow really, really well. So we're going to be able to see the blood flow through those different heart chambers. So if we would like to evaluate kind of more than just the actual physical chambers of the heart, if we want to look at kind of the blood flow to the heart and the coronary artery perfusion and see how well our cardiac muscle is getting blood, we can do what we call a nuclear medicine stress test. So again, nuclear medicine is just another division of our radiology department, like ultrasound and MRI. We can look at this section of the heart with different radioactive tracers. So we give our patients injections of radioactivity at rest and at stress, and we can see if there are any differences or any discrepancies in how the heart is getting its blood supply. Maybe your patient's fine when they are sitting down, but lately when they've been going to the gym or maybe even walking around the grocery store, they've been getting short of breath and some chest pain. So we can go in and kind of figure out where at in the heart that damage is or might start to be, so we can go in and help prevent it. So really cool, just different images. I'm not going to test you on this, just fun for you guys to look at because you will definitely see these in your patient's charts at some point in your career. So here's just, we're going to go real quick through our diseases. Again, these are just some really common diseases of the heart. We are going to discuss coronary artery disease because it is the leading cause of death in the United States. So this is our leading cause of death here in the U.S., and it is due to the accumulation of what we call atherosclerotic plaques inside of our coronary arteries. So those arteries that supply that actual heart muscle with oxygen get blocked up with these plaques that happen because of high cholesterol building up on the walls of those arteries. So eventually this can cause a heart attack or a myocardial infarction. So things that will be risk factors that you'll counsel your patients on: smoking. If they're smokers, we should try to get them to quit smoking. High blood pressure, diabetes, high cholesterol, obesity. So you see a lot of other medical conditions are playing into the progression of this disease. So we will really want to help manage our existing conditions so we don't form new ones. Stress. You'll see this happen a lot in patients who have very stressful jobs, things like that. Sedentary lifestyle, again, promoting exercise. Family history. Some things are just genetic and that's how it is. So we want to also counsel our patients on that. Do you know your family history? Is there somebody you can ask? Can we find out if someone in your family had what they've had? So we can start testing you earlier than we would kind of the standard. So how do we get this? How does this cholesterol get into the walls of our arteries from our digestive tract, right? This is dietary cholesterol that you're eating in your daily diet, and it is going to accumulate on the walls of our vessels. How does this happen? So normally we are going to have a protein called high density lipoprotein, and it is going to be like a little raft that comes to the digestive tract. You absorb all of your nutrients into your intestinal wall. We're going to look at this in a few chapters. And this little HDL, high density lipoprotein raft, little molecule, is going to float on by. It's going to pick up the cholesterol and it's going to take it away for excretion. So it's going to take it to the digestive tract, again, to like the large intestine, and we're going to get rid of it. We are going to get rid of all of this cholesterol that we don't need. Now, we do need some cholesterol. It does have a purpose and is really important. If you guys remember all the way back to chapter 3, when you looked at the cell, we saw that inside of our cell membranes, we have cholesterol. And so all of our cell membranes are going to need cholesterol as they repair themselves and we build new cells. So this protein called low density lipoprotein, or LDL, is also floating around, and it's going to scoop up some cholesterol too. It's going to take it to all the cells of the body that need it. Say, hey, here's some cholesterol for you to repair. Here's some for you, right? It's just like Amazon Prime. They're just dropping stuff off at everybody's house so you can fix up your house however you want to, right? But what's it do with all that extra stuff? It doesn't know. The LDL protein gets overwhelmed, and it does not know what to do when it has too much cholesterol, that all the cells are like, no, I'm good. I have enough cholesterol. I don't need any more. And it goes, oh no, what do I do with it? It doesn't know how to get rid of it like the HDL. And so it just starts throwing it wherever it can hide it. It's like when you have family coming over and you just start shoving stuff under beds and in closets to kind of tidy up a little bit. That is what LDL does. It's like, oh no, I don't know what to do. I'm just going to hide this. And it sticks it all around the body. And for some reason, on blood vessel walls, it really likes to paint the blood vessel walls with this extra cholesterol, especially in the coronary arteries. And so these layers of cholesterol that the LDL is laying down are going to start to build up and thicken and thicken and thicken, and eventually can block off that whole blood vessel and cause death of the tissue that blood vessel supplied oxygen to, because anything without oxygen is going to die. So if that tissue doesn't get reperfused or blood flowing back to it quickly, it could die. So how can we diagnose this? Well, imaging, lots of it. We image this with all kinds of stuff. Cardiac catheterization. So we are going to stick a tube up your patient's femoral artery or their radial artery, and we're just going to wiggle it all the way to the heart, and we are going to clean that plaque up, or we're going to open that vessel back up. And that is called a coronary angiogram. So we can do this this is a type of imaging that we can do to kind of visualize this procedure. And we'll look at a picture of that. We can give some medications to help deal with that cholesterol. We can do a bypass graft where we put in a new artery to bypass that blocked one. Or we can open up that blocked vessel with what we call a stent. And so here's a picture of that. Here is that cardiac catheter, this very thin, flexible tube that the doctor has weaved up the arteries to the heart, to wherever the blockage is. And now we're going to be able to see the blockage on our angiogram over here. And then if we need to, we can inflate this balloon in here to push this cholesterol back down. We can just kind of flatten it to the walls, side of the walls. If it's real bad, we can put in our stent. And so this is kind of like a metal spring that you find in the cap, like the top of a pen. And it's this coiled mesh metal tube that we just slide into the vessel, and the cholesterol now is less likely to build up, and we kind of bypass the cholesterol that's already on the vessel walls. And now we're going to allow blood to flow through here. So that is our coronary angiogram picture. And this is a cardiac catheter with a balloon and a stent. Okay, some congenital heart defects. Again, these are some kind of general heart defects that can occur. There are lots of different things that can occur during development, especially with the heart. Some issues with the heart are just going to be things that were supposed to close that got left open. So these can be seen as septal defects or what we call patent ductus arteriosus. So we looked at the fetal circulation briefly in chapter 21, and we saw that the fetal blood in utero is going to just kind of bypass the lungs, and it's going to flow through a hole in the atria from right atria to left atria called the foramen ovale. And it's also going to flow through our ductus arteriosus, between the pulmonary trunk and the aorta. Now, both of these holes, because they're physical holes where blood's flowing through, should close when the baby takes its first breath due to the pressure. Once we have that increased pressure gradient, that's going to cause those holes to close. And then eventually, over the next few weeks, months down the line, they will fully kind of seal up and there will be no opening at all there. There will be no flap. It'll just be a sealed wall. If those don't close, we can have what we call a septal defect. So if that foramen ovale and the atrial wall doesn't close, we can end up with an atrial septal defect. This is going to allow the mixing of blood, so deoxygenated and oxygenated blood, and it's going to interfere with how well that kiddo gets oxygen to all their tissues. Again, we'll monitor this depending on how severe it is, and that will determine treatment. So you guys will learn more about this when you do your maternal fetal health unit or whichever. They'll talk to you about different heart defects and different birth defects. A patent ductus arteriosus, again, is that opening between the pulmonary trunk and the aorta that stays open when it should close. Again, it's going to cause an increased problem for the ventricles because there's going to be increased pressure. There's going to be mixing blood. It's not going to be good. So again, usually they'll go in and close this one unless it's mild. Again, a lot of different options here depending on severity. No birth defect is really ever the exact same, even if we call it, it's a patent ductus arteriosus. If we have 10 kids that have this, it might look a little differently in each of them. So we're going to adapt what we do to whatever their situation is. We can have a condition called coarctation of the aorta. So this just means the aorta gets too narrow in one part. So we're going to increase resistance. So we're going to increase afterload. So this is going to cause an issue for the left ventricle, and it's going to decrease the amount of oxygen to the body. So again, usually we're going to go in and do a little reconstructive surgery to fix this up. Tetralogy of Fallot. So Fallot is a person's name. Tetralogy means 4 things. So this has 4 problems in this condition. We have an interventricular septal defect. So there's some kind of issue in the septum between the ventricles. The aorta is what we call overriding. It is going to come out of both ventricles instead of just the left. The pulmonary valve is going to be hardened, or what we call stenosed. So pulmonary valve stenosis. So it's going to be really hard for the right side of the heart to get blood out. And that's when the right ventricle is going to have to be very large because it's going to have to be pumping against a increased amount of resistance. So an increased afterload. So that's when we'll see this right ventricular hypertrophy. This is going to cause a lot of problems, obviously, just with 4 things wrong at one time. But we're going to really decrease the amount of blood to the lungs. We're going to have a lot of mixing of blood. This is going to cause what we call blue baby syndrome. So the baby's going to be very blue when they come out. And a lot of times they are. It's fine. They usually pink right up. This kiddo will not. And so we'll need to figure out what's wrong. Obviously, as you can imagine, you can hear this with the stethoscope when you're doing your auscultation. So when the labor and delivery team is evaluating the baby, they would be able to hear this pretty easily. All right. Last but not least is our arrhythmias. So our arrhythmias are going to be an issue with our cardiac conduction system. So there's some problem inside of that network of those special neurons that are connecting the SA node, AV node, all of those guys. This can be a problem that the signal's not getting there enough, and it can cause what we call bradycardia. So again, brady is slow. Cardia, it means heart. So this is a slow heart rate. Or it can cause tachycardia, a fast heart rate. This can start in the atria, so we would call this atrial or supraventricular. Supra means like above, so we would call this the supraventricular arrhythmia, or a ventricular arrhythmia, so associated with the ventricle. So a supraventricular tachycardia, an SVT, so supraventricular tachycardia, is a rapid, regular heartbeat from the atria. So if there is something wrong with some part of the atria, either the SA node or the AV node, and it's causing it to fire action potentials too quickly. So we are having an increased heart rate due to an issue in the atria. We would call that a supraventricular tachycardia. We can have heart blocks, lots of different heart blocks, 1st degree, 2nd degree, 3rd degree heart blocks. You'll learn them. Again, this is just, again, it is what it says. It's blocking the conduction pathway between the atria and the ventricles. So for some reason, we cannot get the signal from the atria to the ventricle. Again, lots of different degrees, different types. So you will learn those in your cardiac unit in your upper level nursing classes. Atrial flutter. The atria is for some reason not contracting regularly, or it is contracting regularly, but they're very rapid. So it feels like a flutter. People will tell you that. If your patient has this, they'll say, oh, my heart feels like it's fluttering. And it's kind of just this weird contraction of the atria. Atrial fibrillation is this asynchronous contraction of atria. This is where the atria are not contracting together. They're not contracting correctly. Blood is not going in the right way at the right time. This can cause your patient to form blood clots and have a stroke. This is bad. If your patient's in atrial fibrillation, we want to fix this. And we do. We have lots of ways to fix this. And again, you'll learn all about them. Another common type of problem is what we call a ventricular PVC, a ventricular or premature ventricular contraction. However it's worded, again, you'll see it both ways. This is where some issue or some area of tissue is going to cause the action potential to fire that is not the SA node. So this is bad. We only want the SA node to fire, right? Keep us a nice steady heartbeat. For some reason, there's some area of tissue that we don't know why has the ability to cause cellular excitation and cause contraction of the ventricle. Again, it is going to be premature. It's going to be before it's supposed to. So it's going to be, the contraction pattern is not going to be in a normal rhythmic way like your heartbeat should be. Ventricular tachycardia, again, increased heart rate due to an issue in the ventricle. Usually causes a myocardial infarction. So we want to correct this as well. Myocardial infarction, again, is a heart attack. So if our ventricles are not beating correctly, or they're beating too fast, we can have a myocardial infarction, and this can be an indication of it. Ventricular fibrillation, again, most deadly. This is where the ventricular wall is just not contracting at all. It can cause complete circulatory failure. So this can completely stop the heart. So ventricular fibrillation, also really bad. We will shock people's heart when we see this. So just some example arrhythmias, some examples of the homeostatic imbalances at the end of your chapter. So that is everything from chapter 20.